and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program. We are excited to bring you Ensuring Holistic Continuity of Care in Women's Health. As we get started, I would like to introduce Dr. Grace Thomas, the Assistant State Health Officer for Family Health Services. Dr. Thomas.
Good morning. Based on the feedback received after our most recent nurse practitioner conference, as well as feedback from the piloted self-history, I'm aware that we are not all in harmony or agreement with the changes being put forth. I know, however, we can agree that our patient numbers have declined over the last several years, and for the most part continue to do so. Like any good organization, when these issues occur, it calls for self-assessment and examination as to how things are organized, structured, and how processes flow. These changes in clinic protocol, the initiation of the self-history, and improving on the follow-up process are all a part of the agency's larger CQI, Continuous Quality Improvement and Efficiency Initiative, to streamline clinic services, improve access to care, and attract our patients back to the county health departments. I encourage you to look at these changes from a new perspective. You may be rolling your eyes at this point and thinking of some choice words for me. But here's why you should embrace these changes. The viability of the county health departments depends on it. Maintaining a good standing in the communities we serve and giving the patients the highest standard and best quality of care depend on it. And frankly, our livelihoods depend on it. You will see more changes in protocol coming down the pike. A more rigorous quality improvement process which will hold us more accountable for our actions while providing a just and fair environment in which to work. We welcome your input on any aspect of these changes, realizing that this is a bit of a sea change for us and will continue to be a work in progress. Thank you so much. At this point, I would like to introduce Krista Hood, who is our first presenter.
Okay.
Krista?
Good morning, everyone. As Dr. Thomas said, my name is Krista Hood. I'm one of the nurse practitioner seniors, and I'm going to be discussing the new protocol for contraceptive management. So for this presentation, please, I know that at the end of the day yesterday, you probably received an email for the handouts and the protocol. We need to use those as we do our presentations today. So if you'll have those ready, we're going to go through the protocol, my presentation, and then the self-history, and then the PAP follow-up. So our objectives for the presentation today, first we're going to review the new ADPH Family Planning Protocol. We're going to discuss the protocol's framework and utility, and then we're going to explain the guidelines for specific risk factors based on clinical scenarios. And I'd also like to say just a thank you to the physicians, the nurses, the nurse practitioners, and the support staff that have helped to develop and edit this protocol over the past 8 months. This has been a big working project, so please just remember that there are a lot of people that were involved, and I'd like to thank everybody that's had their questions or concerns or comments regarding the protocol. So let's get started. The protocol framework, we utilize the U.S. medical eligibility criteria. The framework for our ADPH protocol uses this criteria for contraceptive use. We often refer to U.S. MEC as MEC. This is a general trend nationwide. The Office of Population Affairs within the U.S. Department of Health and Human Services, who administers the Title X program, and the Centers for Disease Control are attempting to standardize care practices. MEC is an evidence-based source of clinical guidance for the safe use of contraceptive methods by women with medical conditions. It is intended to assist healthcare providers, nurses, nurse practitioners when they counsel women, men, and couples about their method choices. MEC includes over 1,800 recommendations for more than 120 conditions and subconditions and characteristics, and also includes information on certain drug interactions. Nurses and nurse practitioners will be able to provide contraceptive care and counseling to patients in our Alabama Department of Public Health family planning clinics that conforms to the evidence-based national care standards that are found in U.S. MEC. This program will outline evidence-based principles that have guided the revision of contraceptive management protocols supported by U.S. MEC and the CDC. Remember, this is our protocol. The information we used was utilized from the U.S. MEC, but has been adapted to include consult information, comments that include evidence-based criteria and clarification, and we've added additional information so that it can be functioning in our family planning clinics. This new protocol will take the place of our current contraceptive management of patients with risk factors that was previously on page 61 of our protocol manual in the family planning chapter. So when we talk about the ADPH vision, what that statement says is the Alabama Department of Public Health will lead the state in assuring the health of Alabamians by promoting healthy, safe, prepared, and informed communities. The vision of our agency is to provide the best care we can for our patients. And the goals of these recommendations is to remove unnecessary medical barriers to accessing and using contraception, thereby decreasing the number of unintended pregnancy. So just keep in mind, through the use of this new protocol, the new ADPH protocol, we are trying to be in line with our vision and our goals. Okay. So next we're going to talk about why is evidence-based guidance for contraception use needed. Well, first, to base family planning practices on the best available evidence. Second, to address misconceptions regarding who can safely use contraception. Third, to remove unnecessary medical barriers. And last, to improve access and quality of care in family planning. Prior to the development of the World Health Organization, or WHO, and CDC guidelines, most contraceptive guides around the world were based on medical textbooks or authors' clinical practice opinions. They also generally address contraceptive use for healthy women, with the result that in many places around the world, including the U.S., women with medical conditions were denied access to contraceptive methods. The CDC and the WHO wanted to develop guidelines that were based on the best available evidence that would address misconceptions regarding who can safely use contraception. And this would remove unnecessary medical barriers, improving access and quality of care in family planning practice. Both documents have been endorsed by ACOG, which is the American College of Obstetricians and Gynecologists. We used to reference ACOG Practice Bulletin throughout our protocol. Now we're going to reference US MEC. Many people and organizations were convened to look at these recommendations and all agree that US MEC should be used in their clinical practice. So we have developed these guidelines for risk factors for Alabama Department of Public Health nurses and nurse practitioners for their use in practice. And it's also, as Dr. Thomas said, the new protocol was developed because there were multiple concerns and complaints about the previous protocol and that it was not user-friendly and it wasn't clinician-friendly. And we need to be more accessible to care and less restrictive on our birth control methods to meet our vision and our goals. So let's get into the protocol. So on page 2, or the table of contents, we discuss how to use this document and the US MEC categories. So for a category 1, and this is really important, you have to know what a 1 through category 4 is to actually use the table. So always you can refer back to page 2 behind in your table of contents if you forget what a 1 through 4 means. But a category 1, no restriction for the use of this method. Category 2, advantages generally outweigh the risk. Category 3, the theoretical or proven risk outweigh the advantages. And category 4, this is an unacceptable health risk to this patient if the birth control method was used. So just remember there's an increasing degree of theoretical or proven risk as we go from 1 to 4, and just refer back through the program if you have any concerns or questions. Okay. We also have an abbreviation table. A copper IUD is abbreviated CU-IUD. The levonorgestrel IUDs, which are your Mirena, your Skyla, your Liletta, and your Kylena, are abbreviated LNG IUD. Implant is your Nexplanon, DMPA is your Depo. POP is your progestin-only pill. A combined hormonal contraception is the pills, the patch, and the rings. When you see an I, that means initiation of a method, and C is continuation of the method. And we've added dashes, which means this method is not appropriate for use. Okay. At the top of each page of the document, you will see a disclaimer. So in the header of each page, and I'm going to read over this, these guidelines are based on one risk factor. So if the patient has more than one risk factor, this document does not apply. So just remember, guidelines are based on one risk factor. We have added a consult column. It's marked by an asterisk. So when you see the number, the numerical 1, 2, 3, or 4, and then or a dash, and then it has an asterisk, this means that there is additional comments about consult or comments in the comment section. A majority of our protocol falls in line with what MEC stated, but we've also, like I said, added the dash and made specific guideline instructions so this could be our protocol. And the type of consults are listed, phone or written, and please avoid the use of the term FYI in your consults. For dispensing categories, let me go back to the consult piece again. I'm sorry. Also, a consult is required for patients recently diagnosed with cancer or cancer within the last 5 years. Our dispensing categories, so if you see a category 1 and there's no asterisk or check mark, which means a consult or a comment about that category, a category 1 would equal to a 12-month supply or a year supply for that patient. Category 2, 6-month supply. Category 3, a 3-month supply. And then when we start initiating birth control, of course, an initial patient that is not established would receive a 3-month supply. And unless she presents to the health department already established on a method and is pleased with that method, you could continue it based on which category she falls in. And then when you do consult, remember to do your initial consult and then update it annually. We tried to make note if there were any exceptions. Depot wouldn't really apply to this rule if it was a category 1. You can't dispense that many shots at one time, so it still is the same. Implants the same. This is more for the pills, the ring, and the patch for our dispensing categories. And then when you consult, if we didn't give supply limits in the comment sections, state, I would like to I'm planning on dispensing a 6-month supply to this patient or a 3-month supply if we didn't already say what we wanted to do in the consult. And Dr. Thomas or Dr. Maxwell or the collaborating physician on call will interject if they don't agree with that plan of care. And then remember, when this document was developed, we did not change the numeration the MEC used for their categories, but we did, like I said, add additional information so that it fits what our ADPH goals are and what we can provide as a health department. Okay. This is just a little graphic that talks about the effectiveness of family planning methods. The way that the U.S. MEC and the selected practice recommendations, or the SPR, are organized, they're organized, their chart based on their effectiveness of use, and that's why it ranges from the IUD to the pills. Okay, so let's talk about our protocol. So if we'll go over to the overheads, I'm going to walk you through the protocol document. Okay. So on page 3 of our protocol, let's talk through age as a risk factor. So again, you can see your disclaimer at the top. So it also tells you, remember, this is one risk factor. When we look at age, we see age with a check mark. So that means we need to look at the comments or the comment section. I believe that we have a more updated version of this, but at the time when I did the handouts, we hadn't adjusted it yet. But there are comments on the other side that would meet up with your comments for your age. So we have several comments about metabolic bone disease, phone consult needed, and just some clarification. So let's talk through from menarche to 18 years. The copper IUD is a 2. The levonorgestrel IUD is a 2. And then an implant is a 1. Depot's a 2. So in this age range, the reason why we've got comments is it also explains why the patient this would be a 2 versus a 1 in this situation. A young woman that has a history of juvenile RA, something like that might have a history of chronic corticosteroid use, that's why the Depot was given a 2. Progestin-only pills are a 1, so you could dispense a 12-month supply. Combined method is a 1. Again, you could dispense a 12-month supply. And then you can see the comments actually go with age in general. It's not a specific comment for any part of the age category there. And then when we look at 19 through 34 years, 35 19 through 34 and 35 through 49, everything is a Category 1, or there's no risk for these methods. So for a 35-year-old, you could dispense a 12-month supply of progestin-only pills or a 12-month supply of combined method. That's if she only has one risk factor. And then when we go on from 50 to 54, everything is a 1 and 2. You get to your depot. Depot is a 4 because we know that we discontinue use of depot as a 4. At the age of 50. So depot is discontinued at 50 years old. And we also have a comment section about bone loss and depot use, and we've added that. And then progestin-only pills, you could dispense a 6-month supply from 50 to 54 years and a 6-month supply of combined method for that patient. And then we discontinue methods at age 55, and that's why all categories are a 4. Okay, so we're going to move on to the next overhead. So we're going to look at multiple risk factors. The reason I brought this one out is because, again, our protocol is developed for one risk factor, but many of our patients have multiple risk factors. MEC listed multiple risk factors as age, diabetes, smoking, hypertension, low HDL, high LDL, and high triglycerides. So if you have a patient that has more than one risk factor, while there are categories listed for the methods, refer back to Appendix B. Appendix B is on page 19 of our protocol. It's the same 2 or more risk factors that we've always used, and that's going to be a slide in just a second. So if you do have a patient that has 2 or more risk factors, and you need information about what methods to dispense, how many you should dispense at a time, if you should do a consult, refer back to your Appendix B, which is your 2 or more risk factors. That table has not changed. We probably at one point in time will edit it to make it a little bit clearer, but at this point in time it's the same table that we have used, and that's on page 19. Okay, and then also I'm going to go on to hypertension, and then we'll get back into our slides and we'll get off the overheads, but let's talk about hypertension again. So hypertension, one risk factor, which is hypertension. It has a check, which means you still need to refer to your abnormal findings in your abnormal findings section for hypertension, the algorithms and guidance for that. This does not replace our abnormal findings sections and some of our method information, just the part of the protocol which talks about contraceptive for one risk factor or for risk factors. So if you have a patient with controlled hypertension, her blood pressure is less than 140/90, methods from an IUD to an implant are a Category 1. Depot is a Category 2. Progestin-only pills is a Category 1, but we've added a check, so you want to look over. So for this patient that has controlled blood pressure, if she is under the care of a physician and her blood pressure is controlled, you can dispense a 6-month supply. The rationale for why we don't want to dispense a 12-month supply for this patient is while if she's being medically managed, has a medical home, things can change through the course of a year, and we wouldn't want this patient to be dispensed a year's supply of birth control and then lose her insurance or not be able to follow up with her physician, her blood pressure become uncontrolled, and we don't see her again until the next year. So that's why we put restrictions on how many we can dispense for this case. And then if a patient presents with a history of hypertension, it is controlled. The combined method is a 3. So there are other birth control methods that are safer for use, but you could also consult and discuss that with your collaborating physician to see if this method is appropriate for this patient to use. And include your consult, the dispensing you would like to use 3 months, just so we can be clear about what your plans are. So let's move on to stage 1. Stage 1 is a blood pressure greater than 140/90 to 159/99. The IUDs through the implants are Category 1. Depot is a Category 2. Progestin-only pills is a 1 with a check, which means we want to look over in our comment section. We would dispense a 3-month supply of pills at this stage. And then a combined method, that's not appropriate for use, so we put a dash in this section. So let's talk about your implants for a second. A lot of times we are apprehensive about removing an implant or inserting an implant with an elevated blood pressure. The biggest concern is, what if that patient with an elevated blood pressure got pregnant? So at this point in time, we don't have any consult restrictions, but always use your clinical judgment about consulting if you don't feel comfortable removing the implant at this point in time, or inserting an implant with an elevated blood pressure. And I'm going to go back over some hypertension things in just a minute, so just remember we're going to discuss the implant part in just a second. So then if we have a stage 2, and the blood pressure is greater than 160 over 100. The copper IUD is a 1. The levonorgestrel IUD is a 2. Then we do have a consult and a comment section about the implant at this stage. And it just states, for implant insertions and or removals with hypertension, you want to consult for guidance. A referral is indicated, of course, with an elevated blood pressure, and we would dispense a 3-month supply of progestin-only pills for this patient. So an implant, a depot, progestin-only pills, those all require a written consult unless you're consulting about the implant, which would be a phone consult. And a combined method is not appropriate for use at this blood pressure reading. And then again, at alert blood pressure greater than 180 over 110, everything has a check or an asterisk. So everything requires a phone consult except for a copper IUD, but you want to make sure you refer the patient to the ER, their primary care physician, as soon as possible for treatment, and alert blood pressure dispensing is 3 months supply. So again, we're going to go back over some slides in just a second about blood pressure, but I just wanted to review the actual protocol with you. So if we can go back to the slides, we're going to go through those now. Okay, so we've talked about age. We've talked about multiple risk factors. We've talked about our 2 or more risk factor table. This is just a graphic that states that there are certain conditions that have an increased risk for adverse health events as a result of pregnancy. Most of those are your people that have 2 or more risk factors, and you want to consider a long-acting, highly effective contraceptive method for these patients. Okay, hypertension, we just talked through that one. So let's discuss some things about high blood pressure. First off, when you get your initial blood pressure reading and it's elevated, you still need to recheck it 5 minutes later. It's not appropriate to just obtain one blood pressure reading and make your decisions about contraception or consult needs based on one blood pressure reading. So first, obtain your blood pressure, and if it's needed, recheck in 5 minutes using an appropriate size cuff. Make sure the patient is sitting with her feet on the floor. Try to make the environment as calm as you can. Tell her to stop using her cell phone. Turn off the lights if you need to. Just something so that you have a good blood pressure reading. And that's just good clinical practice to make sure we check their blood pressures appropriately before we make our decisions. And remember to look at the patient and not just the blood pressure. You may have a patient that is very nervous. Blood pressure could be very high. She's apprehensive about her exam or her implant procedure. And if we allowed time for her to calm down, her blood pressure may be better. You could have the patient who's always elevated. Her blood pressure is 160 over 100 every time she presents to the health department. This may be the best it's ever going to be. It's always uncontrolled. Or you may have a symptomatic patient who is having the symptoms listed, such as dizziness or headaches, blurry vision. So there's different types of scenarios when we're talking about blood pressure. But one thing I want you to keep in mind is you want to look at your patient, you want to look at the blood pressure and make your decision. We don't want to withhold birth control and defer the exam based on their blood pressure reading. If we can dispense a method, we want to dispense a method. And we don't want to change a method. Say the patient presents and her blood pressure is greater than 160 over 100 and she wants her depot. And she's been on depot for multiple years. This is what she's happy on. We don't want to switch her to a less effective method like a progestin-only pill if she could get her depot that day. There is a consult needed for those type of things, a written consult, if to dispense her depot, but we want to provide an effective birth control method for this patient. We don't want a patient that has a chronic uncontrolled blood pressure to get pregnant, because that would be a severe or high-risk pregnancy, and we want to supply the method. That goes back to the implant. when you're looking at a patient that has an uncontrolled or high blood pressure, she's asymptomatic, when you have a stage 2 or an alert blood pressure, that's when you could do a consult. Probably for a stage 2, you might be able to insert that implant, but that's why you need to consult your collaborating physician for further guidance if it's okay to insert this implant or remove this implant. You don't want to send her out without a birth control method. So that's why we put the consults on our stage 2s. And then our alerts, we wouldn't want to send them out either, but that's why we want consults so you don't have to make that decision by yourself. And we also don't want to defer the exam based on high blood pressure alone. If the patient's asymptomatic, we need to complete the exam and dispense her birth control. And then MEC gave additional clarification, and these are hypertension without any additional risk factors that increase her risk for cardiovascular disease. So if you have a patient with high blood pressure that's also diabetic or obese or over 35, go back to your 2 or more risk factor table. Okay. So again, obtain your recheck blood pressure, and if she's asymptomatic, perform your exam and consult your collaborating physician for guidance and follow your protocol. Okay. This is just a little graphic about what blood pressure can do as far as damaging multiple organ systems. And asymptomatic patients that are referred to the ER, we have patients that present to the ER, and sometimes not a lot is done for them right in the ER, so that's very controversial about going to the ER versus seeing your primary care provider. But from a medical legal standpoint, we don't want to send a patient home with the alert blood pressure, so make sure you refer and they get care as soon as possible. So let's go on to diabetes. Let's look at our overheads again. So we're going to do a few more overheads and walk through the protocol again. Okay, so for a diabetic patient, she has one risk factor, and that is diabetes. So they've MEC added a history of gestational diabetes. Everything's a category 1 for this patient. So if you have an uncomplicated patient, so let's discuss what a complicated and an uncomplicated patient is. We previously referred to patients as vascular and non-vascular. Patients that are non-vascular do not have a diagnosis or don't have a history of nephropathy, neuropathy, retinopathy, hypertension, any cardiovascular changes related to their high blood pressure. Their diabetes. So that we've changed kind of the terminology where an uncomplicated patient is a patient without any vascular changes. Complicated has vascular changes or greater than 10 years duration. And even if a patient has been a diabetic for many years, there's probably still damage that has been done to their body. So even if they denied vascular changes or nephropathy or neuropathy, there probably is still some damage that has been done. Uncomplicated diabetics, for a copper IUD, category 1, levonorgestrel is a 2, implant is a 2. This is an uncomplicated diabetic. Depo is a 2, progestin-only pills is a 2. We also have comment sections which state that if the patient is under the care of a physician, we could dispense a 6-month supply for this patient. And a combined method with a written consult, initially and annually, the patient could receive a combined method with 3 months supply. So when we say under the care of a physician, we don't mean you have to get records to verify this patient is under the care. We can most of the time tell from what they give us in their history, if their medications sound correct, if their follow-up plan sounds correct, if they know their lab work and they're checking their blood sugars. So we don't mean that you have to verify any of that, that they are actually under the care. We just want to be a little careful about how often we reassess them and how often they come back into the clinic. So then for your complicated diabetic, your hormonal methods all have an asterisk by them, so they all need written consults initially and annually. So for like a depo, you have a category 3. With a written consult, there's a lot of patients that come in to see us that would like their depo and they are a complicated diabetic. So with a consult, if the collaborating physician feels like that patient can receive her depo, we want to continue that method. Progestin-only method is a 2 with a star and a check. Progestin-only method is a 3-month supply. A 6-month supply unless they're not under the care of a physician, and that would be a 3-month supply. And then we'll move on to headaches. I'll go ahead and do headaches before we go back to our slides. So headaches. We have a check mark by headaches, which means you need to make sure you assess for an accurate diagnosis of headaches versus migraine, and aura is necessary. So we're going to discuss that a little bit further also. So for a non-migraine headache, all methods are category 1. Migraines without aura, including menstrual migraines. Methods are 1, and then a 1 with a check for your progestin only, which means a 6-month supply. And your combined method is 2 with a check. We want to make sure, so a 2 would be a 6-month supply also. So if the patient has more than one risk factor, that increases her risk for stroke. So a COC with more than one risk factor, you would want to refer to Appendix B for further guidance. And then if the patient had migraines with aura, all categories that are hormonal require a consult. They are listed as a 1 by USMEC categories, but because there are migraines with aura, we require a consult. And then a combined method is not appropriate for use because of the risk for stroke with these patients. So if we'll go back to our slides, we'll discuss those a little bit further. Okay. So we talked about diabetes. Okay. My head does hurt, doesn't yours? So let's talk about headaches a little bit further. Okay. Some of the things that Nasa and Luzini are going to discuss in your self-history are looking at their medications. When a patient lists a history of topiramate or Topamax, you just want to be aware that certain anticonvulsants that are also used for migraines can lower the effectiveness of the birth control method, increasing the likelihood of pregnancy. We want to make sure we provide education on the use of a backup method, and just be aware that the medication like Topamax does increase the risk for certain birth defects. So when you have a history of headaches, we want to make sure we assess for and determine the type of headache and whether it's a migraine. So we want to assess multiple characteristics. The reason why this is such an important issue is because headaches can be a symptom of a more serious problem, and headaches and migraines are a common consulting issue. So we've added additional information through Appendix H on page 26. It was the same information that was in our previous protocol, and it helps go through determining types of headaches, migraine characteristics, and signs and symptoms of migraines, and then migraines with or without aura. But we're going to talk through some of those. So for migraine characteristics, you want to determine the onset, the location, the frequency, the duration, exacerbating and alleviating factors, symptoms, and triggers. And these are some things that you may tease out through your history when you discuss migraines without aura. Patient may complain of nausea, vomiting, sensitivity to light or sound, or visual blurring or a movement that makes the headaches worse. Remember, a common migraine is a disorder involving recurrent headaches that may have a broader set of changes, including the ones just previously mentioned. Some patients may even have a prodromal phase, which includes a sensation that the migraineur can feel before the attack happens, but it's not a focal neurological change or an aura that we're going to discuss. So migraines with aura. The patient may describe unilateral numbness or weakness, a pins and needles sensation, or paralysis. May also discuss visual disturbances in one or both eyes, like zigzag lines, blindness, blind spots, or loss of vision. That is a more significant change. So we're going to discuss some things about migraines with aura. And she also may discuss difficulty speaking or smelling odors that are not present. The most important significance of migraines with aura is that they oftentimes can mimic stroke. So migraines with aura, some people also experience visual and sensory disturbances before the headache begins, which is known as the aura. Some disturbances generally last somewhere between 30 to 60 minutes. In some cases, do not result in a headache. Auras may change in frequency over the patient's lifetime. But just remember, the hallmark of the aura is that it begins before the headache and it abates when the headache begins. And the visual change and neurological change is the most common disturbance. And just a little FYI about strokes and migraines. There's about 28 million women in the U.S. with migraines, and the number of strokes per year related to this diagnosis is about 3,600. So when we're talking about prescribing birth control to a patient with migraines, we really need to get a good history to make sure whether she has a headache, a migraine, and whether an aura is present because of this risk of stroke. And these are just some terms that the patient may list when you're doing her history. Okay, so let's go back to our overheads, and we're going to discuss a few more risk factors from our protocol. So thyroid disorders. When we did the conference in April, there have been changes made to the protocol, so just be aware of those. I think we said that all thyroid disorders required a consult, and we've kind of clarified that a little bit. So a thyroid disorder, patient with a simple goiter, hyper or hypothyroidism, all methods are category 1. So when you get to a progestin-only method, at your POPs, we do have dispensing guidelines and comments. So if the patient is asymptomatic and she presents, she's under the care of a provider, and she's not having any symptoms that we are concerned about that day, then that patient can be dispensed a 6-month supply, and we don't have to obtain labs for this patient. So unless she's symptomatic or this is a new finding or doesn't have access to primary care, then that's the patient we want to take labs on. If she's symptomatic and not under the care of a physician, then you would obtain your thyroid profile, and if the results are abnormal, refer and consult. If she's followed by an outside provider, no lab is needed. For thyroid storm, you would make sure you do a phone consult and refer. And so for dispensing, 6 months is okay for these patients who are under the care of a physician, and if she's asymptomatic and is not under the care, that's when you would obtain the thyroid profile and dispense 3 months and consult and refer. So in your consult, you want to assess for the severity and the symptoms related to the hyper and hypothyroidism. And then, of course, for thyroid cancer, that's a phone consult for all methods. So we'll also look at hepatitis. So this is a patient that's either diagnosed with hepatitis or presents with a symptomatic liver disease, which we are not able to diagnose hepatitis in the clinic. So you might have a patient that presents that has acute signs and symptoms such as jaundice, ascites, and large liver upon palpation of their abdomen. This patient is very sick, so we've put for all methods that no method is appropriate for use in this patient, and a phone consult would be needed because we are going to discontinue a method. This patient, we can obtain liver function testing and refer. But if a patient presents that is a carrier or chronic, all methods are a 1. We do not have to obtain liver function testing for these patients. They're asymptomatic, liver function testing is not required, and you can dispense up to a 6-month supply. Okay. And then anemias. So for anemias, we have a check mark, so you still want to refer to your abnormal findings chapter for help as far as dispensing or doing the follow-up and what methods or what like iron is needed when you have an anemic patient. So let's look at sickle cell disease. For your depot patient that has sickle cell, depot is preferred because it helps prevent the painful sickling crisis. And a combined method would require a consult due to increased coagulation activity because a clot that could form in this patient is different. It's a vaso-occlusive clot, so a combined method may not be the best method for this patient, but that's when we want to consult for further guidance. And then iron deficiency. Any anemia that is unexplained and undiagnosed with a hemoglobin less than 10 requires a referral. And just remember, there's an increased risk for colon cancer in African American females greater than 45 years. So we dispense the FIT testing kit and make sure you recheck hemoglobins in 6 to 8 weeks per our abnormal findings chapter. And then the last one we're going to look at is valvular heart disease. Valvular heart disease could include mitral valve prolapse, mitral insufficiency, regurgitation, or murmur. So when we have patients with valvular heart disease, you want to make sure you also assess their heart rate. If you have a complicated case where she's symptomatic, which means she has chest pain, shortness of breath, exertional symptoms, tachycardia, palpitations. This is a complicated patient. So she does require a consult for all methods. And then, of course, our combined method is a category 4. So consult on those. And then unsymptomatic, everything is a 1 except for your combined method, and that's a category 2. So this is a patient that does not have any signs and symptoms of shortness of breath, chest pain, palpitations. So let's go back to our slides and finish up with this part of the program. So we've discussed thyroid. We've discussed our hepatitis section, our anemias, valvular heart disease. So we've gone over 10 sections of the new protocol, and I chose the 10 based on what I felt were most common, what we consult a lot about, and what we had changed from our previous protocol, and what I thought we should point out. That's how we kind of decided about those. So I want to point out the last parts of the protocol. We have multiple appendices following the contraceptive risk factors protocol. So I just want you to pay attention to Appendix A. That one's new, the low-risk patients with breast masses. Appendix E is indications for extended use of hormonal methods. That was the new protocol change for the use of the NuvaRing, extended cycling the NuvaRing. Appendix F was an antiretroviral therapy list. And then Appendix G is how to be reasonably certain that a woman is not pregnant. So we're going to go over that one, and we've already discussed identifying migraine headache tools and forms. So Dr. Thomas always says, this is hot off the press, and while we're developing protocol, she always says this term. So I thought that was kind of cute. Anyway, for consultation, this is a new change that's new with this protocol, that nurses can consult the collaborating physician. I do want to say there are some nurses in the state that already consult the collaborating physician by phone and do a follow-up email. So we just wanted to standardize this and kind of give directions and guidance for going forward with consultations. And I also want you to keep in mind, if we were working with Dr. Thomas, say in labor and delivery, as the nurses, we would often speak to the physician. So it's not a new topic that the nurses consult the physician. It's just something that routinely the health departments did not do. So I do want to mention that I know that it is a change, and we're working through how to make that a little bit clearer. So if a patient presents for a supply visit, a deferred physical, and the nurse practitioner is not there, say you're in a clinic where you don't have a nurse practitioner that day, the patient either has an elevated blood pressure, has multiple risk factors, but she needs a birth control method that day. So this is a patient where it is acceptable for the nurse to consult the collaborating physician. The nurse practitioner is probably working in another clinic. She may be off, she may be driving. It may take a lot of time for you to get someone else on the phone. That nurse practitioner is not with that patient at the time. She can't really get a good history. She's not the one taking the history, and she may still have to do a consult afterwards. So it's hard for that nurse practitioner that's not with that patient to put through the consult. So that nurse can take the history, and we've got some guidance on what we needed included in the history when you're calling, and what to do. So if you have a patient that you cannot dispense a birth control method, you need assistance, you need to consult, you can call the collaborating physicians, and we do get an on-call list per week of who's on call and what's the best number to reach them. So first, before you call, I want to change slides and get a few things. You want to make sure that you list, that you tell Dr. Thomas or Dr. Maxwell the age of the patient, how many times she's been pregnant, how many deliveries, last menstrual period, vital signs if there's anything abnormal. A lot of times we'll include their BMI if it's elevated, and their blood pressure. We want to get a pregnancy test on these patients. We did initially say that was an optional because you might not have gotten a pregnancy test that day on that patient, but for when you consult, it's always a good idea to have one on hand. The reason for the consult, so make sure you have everything in front of you, and you already have asked all these questions before you call. Make sure you list the reason for your consult and your plan. So if a patient presents and her blood pressure is 160 over 100, she'd like to continue her depot, you could state that in your phone call and ask if this is an appropriate plan, and they can give further guidance. You could also list if she's symptomatic or not symptomatic, and then this is all going to be written up in an email following your phone call, and then you would want to CC the nurse practitioner and print it once you've got your response and from the physician, and print it and place it under the consult tab. So all this needs to be turned around and put in the chart within 72 hours. So the process is completed within 72 2 hours of when the patient was actually seen and the phone call was made. I know with the 2 or more risk factors table, we still had the little MP stamps, so we are going to edit those eventually out. But for the use of the protocol, this is a nurse and a nurse practitioner usable protocol. So if you're following protocol and you see that the method has a 1 with a star and you need to consult, the nurse or the nurse practitioner can do that consult. If she has 2 or more risk factors, the nurse or the nurse practitioner could do that consult. So I know that's a big change, and there's probably going to be some questions about that, but I just wanted to try to explain how this kind of came about. And then we're going to go on to how to be reasonably certain that a woman is not pregnant. When we talk about how to be reasonably certain that a woman is not pregnant, that idea is different than how to rule out pregnancy, and that is different than when to start a method. So we're going to talk about those 3 topics. So the first is how to be reasonably certain that a woman is not pregnant. And what happened was that we would run pregnancy tests, because it's still part of our visit standards to do a pregnancy test with the initial and the annual. So we would run a pregnancy test on a patient that was status post elective or spontaneous abortion. Pregnancy test would be positive because she was still within that time frame when the hormone would still be in her urine sample, and we'd have a positive test result and would not be able to provide a method. But we were also reasonably certain that she was not pregnant, but we have a positive pregnancy test. So SPR kind of gave some guidelines on how to be reasonably certain, and in these cases, we're not saying that your initial and annuals you shouldn't get a pregnancy test. I'm just saying that for patients that might be that patient that is just had a miscarriage or an abortion, that would be a patient that if you're reasonably certain that she's not pregnant, you would not do a pregnancy test on that patient. That would present another barrier to her where she would not be able to get her method and have to come back. But again, reasonably certain is less than 7 days after your start of your cycle, no intercourse since the start of the last cycle, correctly and consistently using a reliable method of birth control, or less than 7 days after a spontaneous or induced abortion, or within 4 weeks postpartum, or fully or nearly breastfeeding. I know that we also, when it goes back to the less than 7 days after spontaneous or induced abortion, we do have another statement about in the how to rule out pregnancy about several weeks after when that occurs about the pregnancy hormone. So we'll go through that. So just remember that how to rule out pregnancy and how to be reasonably certain are 2 different things. We wouldn't be ruling out pregnancy if we were reasonably certain that she was not pregnant. So when you do have a patient that you are not reasonably certain that she's not pregnant, that's the patient we rule out pregnancy. So when we added this part of the protocol in March or April, it was kind of unclear about what do you do about the patients that cannot get ECP or are greater than 7 days since their cycle. What do we do? How do we dispense Depo in these patients? So we needed to put that back in because that wasn't clear. So how to rule out pregnancy, abstinence or no unprotected intercourse during the past 2 weeks, and a negative pregnancy test. And if there's any unprotected intercourse during the past 2 weeks, the patient's not a reliable historian, obtain a pregnancy test that day. If it's negative, the patient still needs to come back in 2 weeks for a rule out to do another pregnancy test. And if it's a first trimester abortion or a postpartum patient up to 28 days post-delivery, the pregnancy test, the HCG levels may remain detectable for up to 3 to 4 weeks, so that causes the false positive. So if we're reasonably certain in that case that she's not pregnant, has not had unprotected sex, has been abstinent in that time frame, then that's the patient you would not obtain the pregnancy test on. Make sure you get the reliable history, and if there has been unprotected intercourse, rule out pregnancy before you initiate a method. And make sure you counsel the patient appropriately regarding this and how we initiate methods. Now you can also, if you cannot rule out pregnancy and the patient is there for Depo, you cannot dispense the Depo, you could provide Plan B if she's still in that window for Plan B, initiate POPs, and then provide Depo when the 2-week rule out happened. We want to start the patient on a method as soon as possible. We don't want to send the patients out without a birth control method. So sometimes condoms are not enough, or they're not going to use condoms. So you could do ECP if that's appropriate in that time frame, progestin-only pills, and then start Depo the next time. And these patients that come in, their status post-abortion or miscarriage, these are high-risk patients that they could get pregnant again. So that's why we want to make sure we don't prevent them from getting a method because we have a false positive pregnancy test on their chart. So we don't want to present another barrier and they get pregnant again. So then, in some situations, it's the discretion of the nurse practitioner, and pregnancy testing is not indicated, and that's what we talked about on how to be reasonably certain when we're not going to do pregnancy test. So when to start, these sections are listed with every birth control method in our protocol. So I just wanted to make you aware that we've changed it from, it used to say within 7 days of the onset of your cycle that you could start a birth control methods, within 5 days. That's changed to 7. And then if later than 7 days, rule out pregnancy. And then for the non-breastfeeding postpartum patient, it used to say 4 weeks. That has changed to 6 weeks because of the risk of blood clots in the postpartum period. Okay, finally, while I said that this is our protocol, this is not everything that we've listed is not everything that MEC lists. Sometimes people just want a little bit more clarification and guidance on why the categories were the way they were. There are apps that you can download. I don't want you just to use the US MEC apps or the SBR apps. You still need to use your protocol, but I just wanted to make you aware that there are things that you could use that sometimes make it a little bit easier, but always use your protocol. And there's just some guidance about that. And we gave a summary table at the conference, and it also had the categories in green and in red. And you can utilize that also, but just remember when you're talking about whether or not you can dispense a birth control method or order a birth control method, you need to use our protocol because not everything, we use the USMEC framework, but this is our protocol. And there's just some additional quick reference charts. And just remember, I know this is a lot of information, but keep calm and stay positive. We're trying to move in another direction with how we do business as we transition into electronic health records or electronic medical records. Things are changing, so I just want you to please remember that this is all meant to be a positive transition. So if you have any questions or concerns, please call or email, and Deborah is going to give you our number so that you can always call us or email us. We really appreciate all the comments and the clarifications that were asked for, and it helped to make this a better tool. So please let me know if you need anything. Thank you.
So if there are no questions, we'll hold till the end of Luzenia Lawson's presentation. And I would like to introduce Ms. Luzenia Lawson. She is the nurse manager for Family Health Services, and she's going to start our topic on the patient self-history form. Luzenia.
Thank you. Good morning. I have met many of you since I've been here since August, and I look forward to meeting more of the clinical staff along the way. Doctors Miller, McIntyre, Thomas, and Maxwell, along with Ms. Beth Allen, the nurse practitioner seniors, Mr. Chris Hall, Ms. Teresa Lawson, Ms. Norlisha Lampley, Ms. Dina Donovan, and the staff at the county health departments who piloted the patient self-history forms, and I have worked tirelessly to compile the form that I will review with you today. Thank you to everyone, including the patients who have helped us to this point. The patient self-health history form has been piloted in 7 counties from April to June of 2017. We requested feedback from the selected counties. The feedback was very helpful in making the form more concise. We integrated some of the feedback We integrated some of the suggestions into the revised form. This is an evolving document. It is not written in stone. As we push forward, there will be changes. In addition to the annual patient self-health history form, we have the patient history update form. I will review it as well during this training. The annual patient self-health history form is good clinical practice. It is 3 pages long. Please note that this form replaces CHR 12A, page 1. I'm going to give you an overview of each section. Ms. Nasa Hernandez, our nurse practitioner senior, will provide a detailed review of each section of the documents so that the question why is answered to each of the sections. The objectives. Discuss the annual patient self-health history form. Discuss the patient self-history update form. Do not fill out the current CHR 12A, page 1. The annual patient self-history replaces this. It's very important. We only want to have one document for the self-history. The clerk will check the visit type in the for use only box. The patient will fill out the remainder of the form, starting with the patient's full name, age, and the current date. The patient is asked to state the reason for the visit and to list any allergies. Check whether yes, the nurse will check whether yes was marked, indicating the patient has attended any other health departments or has been to the hospital and or the emergency room. If yes, ensure the patient responses are documented. The patient is asked to check the yes box or no box for their medical history. Check the box next to any medical conditions of first-degree family members, and check the boxes for all applicable symptoms. On page 2, the nurse will review and assess the patient's list of operations/procedures, list of medications, answers to gynecological history questions, answers to obstetrical history questions, answers to sexual history, and contraceptive history questions. Let's look at the overhead for the patient self-history form. Each page of the 3-page document has an area for the patient label. It's on the top right corner. And the clerk will place the patient label there. Also, there's a box for office use only. The clerk will make the determination about the visit type. The patient will fill out the remainder of the form with their name, age, the reason for the visit. Under medical information, they have their allergies, ER visits, etc. Under medical history, the patient will denote if any of these conditions are applicable. Under family medical history, they will denote their first-degree relative conditions there. We'll move on down to the review of systems. Any of those that are applicable, they will mark. Page 2, please. They'll list any surgeries that they've had in the box there, and any medications. Below are the histories, gynecological history. Again, Ms. Hernandez will go in depth with regard to each of these sections. So this is a high overview. Obstetrical history, social history, sexual and contraceptive. Below, the patient will sign their name. Now, let me interject here that if it's a non-English speaking patient, then if you have an interpreter on site, that interpreter will sign their name as indicated there. However, most often the language line is used. Then we will need to have the translator number placed there. This information that the patient has documented for us will need to be reviewed by the nurse. Her signature is required at the bottom, and then it needs to be reviewed by the nurse practitioner, whose signature goes there. Moving on to page 3. Page 3 is the comments page. At the top, you'll see nurse's comments. It's required that the nurse make a comment regarding her assessment of the patient, regarding the yes answers or yes responses or any other comments the patient has made regarding to their visit for that day. Then, of course, we have a space for the nurse practitioner's comments and signature. Okay, we'll go back to the slides, please. This is just a recap of what I've already described in the form itself. And Ms. Hernandez will go over these much more in depth. And I do want to make the statement: the family planning nurse should review the form with the patient to ensure all questions have been addressed and any yes responses are assessed as needed. Now, let's move along to the update form. Let me go back for a second. For the patient self-history, this form will be filled out annually. Now, with the patient self-history update form, it will be filled out for problem visits and deferred physicals. The patient self-history update form provides for the documentation of current health information for the patient who's having a problem visit and deferral visit. After the patient self-history update form has been completed by the patient, the family planning nurse should review the form with the patient to ensure all questions have been addressed and any yes responses are assessed as needed. The family planning nurse must write a comment and sign the form. Check the box to indicate what service the patient will receive during the visit. Place a label on the upper right side of the form. Check the patient's full name, age, and the current date. The nurse will also check whether any yes responses were marked, indicating the patient has any new medications or allergies. The update form basically is utilized to show any changes in the patient's health since they filled out the initial annual patient self-health history form. And that just recaps the categories that Ms. Hernandez will review. Are there any questions?
I don't know if we have any online questions. You're certainly welcome to call. I want to just reiterate what Luzinia was saying about the forms. We actually have the 3-page self-history form and the update form, along with a PAP follow-up note and breast follow-up note that we're introducing today. Those forms are available in the document library under the CHR manual section. It is the first 4 forms in that section now. Tried to make that a simple process for everybody to be able to gravitate towards. Of course, the forms are in the packets for today's teleconference, and if y'all have any questions regarding that, please feel free to call. We have a little time for those questions. If we don't, y'all can gather your thoughts, and we will go to a break for about 10 minutes, and we'll come back and have the second portion of the final sections of our teleconference. Thank you.